Good afternoon, everyone, and welcome to the GLPP HIIN and Minnesota HIIN Sustainability Webinar Series. Today, we will be covering healthcare-acquired infections. A few housekeeping announcements before we get started with the presentation. All lines will be muted. For those of you using PC audio, we ask that you please mute your lines throughout the presentation due to additional noise feedback that may occur. Throughout the discussion and during the Q&A portion, feel free to use the questions panel on the right side of your screen. Additionally, the session will be recorded and we'll post the recording and slides on the MHA community site. If you have any additional questions outside of the webinar, please email keystone@mha.org. With that said, it is my pleasure to hand it over to Jenny Winkler from the Illinois Hospital Association to start us off with the presentation.
Everyone, thank you so much for joining us today. Go ahead. Move our slides forward. So I want to introduce myself. My name is Jenny Winkler. I'm a Director of Quality, Safety, and Health Policy at the Illinois Health and Hospital Association. And I don't know, Naomi, I'm sorry.
You're good. Jenny, if you just want to click on your screen and then use the arrows to move yourself forward.
Yeah, I'm doing that and it's not working.
Okay, I can move them forward.
Okay.
See if it works now, actually. Okay.
Not.
I can help move them forward if you just want to say next slide.
Yep, let's do that. Okay, so go ahead in the next slide. Still doesn't look like these are moving. Okay.
I'm going to stop sharing my screen and then reshare.
Perfect.
Okay.
All right. Sorry guys for the technical difficulties, but so really quick, I want to talk to you guys about a couple things that we've done in Illinois related to HIIs. And so this slide covers that. Our implementation playbooks, we'll take a deep dive into two of those playbooks. And then I want to share with you some information about IHA's Innovation Hub. And so the first thing I want to start with is introducing our implementation playbooks. Okay, nice, it works now. So these playbooks were something that we had developed as a result of a program in Illinois called our Innovation Challenge. And so what that was is we identified hospitals that had a unique approach to addressing either a hospital-acquired condition or readmissions. And then we would work with that hospital to replicate that same unique approach in a different organization that was in a completely different part of the state. And so based on the experiences both organizations had with implementing those approaches, we developed these implementation playbooks. So that way we could help other hospitals implement that same process in their organization. So this slide here lists a couple of the implementation playbooks that we have available on the website where they can be downloaded. And so I want to give you an overview, a little bit of these playbooks. So our goal with these was for us to develop an easy to use digital resource that had a different look and feel from a traditional toolkit. So, you know, as you go through, if you download these playbooks, you'll see that they really have kind of that similar look and feel. Each one of these playbooks has some general information, of course, about how to use the playbooks. And something that's really fun that is also lists a cast of characters, and you can see, for example, in the playbook that's on your screen here, there's characters on the right-hand side, and these are key individuals from each of the organizations that implemented these unique approaches. And so above them, you'll see that there's a little caricature, and that caricature is embedded throughout each of the playbooks and has some kind of comments from each of the organizations and tips and tricks that you can use to implement these same approaches in your organization. So each of our playbooks has some general information, of course, about the projects that these hospitals did, and impacts about and information about the impacts of each of these unique approaches. And then each one of these playbooks gets into the specifics of what each of those programs are. And so each approach is broken into specific steps. And each one of those steps has information around the key activities related to those steps, some keys to success that these hospitals identified as they were working through this process, potential challenges, and a variety of tools and resources that these organizations used that are applicable to each one of these steps in their process. And so that's kind of an overview of what our playbooks look like. And what I want to do now is dive into two of them that really had a specific focus on HAIs. So this first playbook was developed by a 150-bed community hospital in the city of Chicago. And so this hospital had noticed an increase in their number of catheter-associated urinary tract infections and central line-associated bloodstream infections. And as a result of that, they established daily huddles that were used to review infection control practices and address the device utilization, and then review any device-related infections that had been identified. And so we'll go ahead and take a closer look at this playbook. As I mentioned previously a few minutes ago, each one of these playbooks has some introductory information, but I really want to talk through the steps that this hospital did with all of you. So the first part of implementing these interdisciplinary safety huddles was really setting up your meetings. So finding 15 minutes during the day where all of the units could attend and all of the key participants could attend. And so in this hospital, this included nursing unit managers, the infection prevention staff, leadership staff, which are key for ensuring that the people are held accountable through the process, and the infectious disease physician that provided guidance and oversight for the infection prevention department. So first step in getting this all set up. The second step in this process was really was around developing a form that they could use to track device information that was shared during the safety huddle. So in this specific playbook, there is an example of the form this hospital used to track that device information. And so that included information about the specific type of device, the location of the patient, the indication for use, the date of the device placement, a removal plan for the device, any barriers that had been identified for removal, and any follow-up or next steps that needed to be shared with the group. And so again, another thing I want to share with you, so each one of these steps has those specific resources embedded in them. And so on the bottom of this page, you can see there's the device form that was developed by this organization is highlighted with a little arrow, and it's called the Daily Dish device form. So those resources will be embedded across the playbook. So the third step that this hospital did really focused on the unit reporting, and that shows the unit reporting about their devices. And so each unit manager in the hospital would have an opportunity to provide information either about the central venous catheters or any of the intrauterine catheters that were in place on their units. And one of the huge keys to success that was part of this step in their process was that there was a significant increase in the awareness around devices that were in place on each of the units. And just by having that increased awareness, significantly contributed to the success of those units with removing their devices. So that was a big key finding that this organization identified. through their process. The fourth step in their program was really focused on device removal. And so during their huddles, the infection control team was able to provide recommendations for unit staff about when devices should be removed. And so using their tracking form, every day when these huddles take place, including weekends and holidays, they're able to look back and see, if the recommended devices were removed. And then as a result of that, in step 5 and 6, that really focused on interventions. And so providing the support that unit staff would need for the removal of devices when they might not necessarily, or when they have identified barriers or when these devices were not indicated. So oftentimes, I'm sure many of you have experience with this. Clinician preference is something that is commonly cited as a barrier for not removing a device. And so by having these huddles, unit staff were able to share feedback with the infectious disease physicians and the hospital leadership about these barriers with clinicians, and then leadership and the physicians were able to initiate those discussions with clinicians. And so, with that really leads to the last piece of the process that this hospital implemented, and that was the accountability piece. And so having leadership actively participate in their huddles was really essential for these hospitals to maintain, or for these clinicians and for the unit staff to ensure accountability to make sure devices were removed prior to the next safety huddle. And so throughout this process, I want to share with you the next slide. There were the results and impacts, just from implementing these 15-minute daily safety huddles. And so one of the comments, it took them a few months to get this process implemented in the hospital and to start working out some of the kinks. But, just looking at this slide, you can see having these 15-minute huddles, the organization was able to reduce their CAUTIs and CLABSIs by 90%. And then with that decrease infection, with the decrease in infections and the decrease in device utilizations, they demonstrated almost $500,000 in cost savings. And so this was over the first year of the program. So very impactful strategy that these guys used. The second playbook that I want to share with you all real quickly is this new road to C. diff reduction, and this is a playbook that focuses on reducing hospital-acquired C. diff infections in a 400-bed hospital in Springfield, Illinois, which is in central Illinois. And this hospital determined that they needed to implement some kind of change in response to high rates of their hospital-acquired C. diff infections. And they decided to focus on reviewing C. diff orders to ensure that tests were ordered appropriately, and then the implementation of a C. diff bundle that included a variety of interdisciplinary approaches that helped them identify and reduce C. diff when patients were admitted to the hospital. So I'll go through this real quick. The first step in this is, you can imagine, developing a process, where you're reviewing testing orders and implementing a bundle can be extremely daunting. So the first step in their process was really working on that implementation preparation piece. And so establishing the team, defining the team roles, determining parameters, that they were going to use to identify whether a test was ordered appropriately, the policies, the protocols, and an education plan for rolling out this process were all included in this step. And so there's a lot of small steps included in this. And in this playbook at the bottom of the screen, you can see there are several resources that the organization used to help put this process in place. And so, if you're interested in downloading this playbook and utilizing those resources, I would recommend doing so. It covers all of those little steps in the implementation process. The second piece of the next step in their program focused on their daily workflow, and then ensuring that there was appropriate training to assess patients when they were admitted to the hospital to determine if C. diff testing might be appropriate. And so this is the step where the C. diff test would be ordered. And in this hospital, they determined that the infection prevention staff were the ones that were going to be reviewing all of the orders. So the IP staff would review a testing, had developed a testing checklist that they would review anytime there was a C. diff ordered. And then that would be the resource they would use to determine if the test was appropriate. Also to note, all of the resources developed by these organizations were developed by an interdisciplinary team, so they had input from a variety of departments. Another piece of this, as we know with any quality improvement project or any type of implementation of a new process, one of the most important steps for us is to ensure that we start small. And so this hospital started with one unit implementing their new process, and then they expanded from there. So the next step in their process, in addition to reviewing all of their C. diff tests, they implemented what they considered, what they call the C. diff bundle. And the C. diff bundle is a multidisciplinary approach that they helped with identifying and containing any potential C. diff cases. So the bundle's components included early recognition of C. diff cases, tools to help their nursing staff so they know when to initiate isolation, when it's appropriate to test, hand hygiene education and stressing the importance of using soap and water, cleaning recommendations for environmental staff services, patient transport guidelines, and patient and family education resources that were all specific to STIF. And so, it looks like maybe I skipped a slide. So, so there's a lot of information packed into this step. And so, again, encourage you to look at any of the tools that these guys might have available. If this is something you're interested in replicating in your organization. And so I apologize, I don't have the results and impacts on this slide, but just so you know, after a year of implementing this testing review process and the implementation of the C. diff bundle in the entire hospital, this hospital saw a 78% reduction in their hospital-acquired C. diff infections. And that ended up saving the organization almost $600,000, which is quite significant. So the last thing I want to share with you guys is about our IHA's Innovation Hub. And so this is the website where all of our innovation playbooks are housed. So in addition to those two playbooks and those two strategies that I shared with you, you can visit this website to download those playbooks and any of our other ones that focus on social determinants of health, emergency department recidivism, antibiotic stewardship, and sepsis, which will be posted in the coming weeks. Our hub, in addition to the playbooks, also has features for our members that include an innovation of the month, different tools and resources that you all can use to start replicating these strategies that are described in each of the playbooks, and a community site where you can connect with other hospitals that are also utilizing the playbooks. And so you can click on the banner on this slide, and it will take you directly to the Innovation Hub where you can see how those resources can support your organization. And so with that, I want to go ahead and stop, open it up for any questions that you might have.
Hi, Jenny. I am not seeing any questions come through the questions panel.
Okay, perfect. All right. Well, for those of you who have any questions, feel free to put them in the chat box. And with that, I will move us. We can go one more slide over, and I would like to turn things over to Jenny Schonecker, Senior Director of Quality and Safety at the Minnesota Hospital Association.
Great, thank you so much, Jenny. Hello, everyone. My name is Jenny Schonecker, Senior Director of Quality and Safety with the Minnesota Hospital Association. And I'm really excited to be here today to share about some of the work MHA has done on HAI and the different tools and resources that we have available that you may find useful. All right, so MHA has a handful of different committees, and the HAI committee is comprised of HAI experts from across hospitals and health systems. And they really lead our HAI work. So they oversee the HAI roadmaps, coordinate the HAI learning networks, and collaborate on other HAI resources that are made available to hospitals and health systems on our website. You can see here just our committee structure. The HAI committee reports up to the Quality and Safety Committee, who then report up to the board. So we have some really good alignment. There are 5 HAI roadmaps: CAUTI, CDI, CLABSI, SSI, and VAE, and these are all available in PDF format on our website. The roadmaps provide hospitals and health systems with evidence-based recommendations and standards for the development of topic-specific prevention and quality improvement programs, and they're really intended to align process improvements with outcome data. So the roadmaps reflect published literature and guidance from relevant professional organizations and regulatory agencies, as well as identified proven practices. And the MHA Quality and Safety Committees provide expert guidance and oversight to the various roadmaps. So the HAI committee really oversees all of these roadmaps. They review them on a consistent basis to make sure they're updated with current practices and standards. All right, so the roadmap structure, you can see here on the screen. This is just a little snapshot of what a portion of the roadmap looks like, so I'll go over that for you. The roadmaps are organized by sections to address specific aspects of care. So you can see here, the section is patient and family education. The elements of the roadmap are tiered into fundamental and advanced. So the fundamental is where you want to start out. It's your basic elements, and then the advanced elements you would want to work on implementing once you have all of your fundamental elements in place and are able to continue to keep those ongoing without losing sight or focus on those elements, fundamental elements. The roadmap is audit style, so it can be used as a working document for quality improvement. You can see the check boxes. And operational definitions are included, and those are meant to give additional information to ensure all hospitals are interpreting them the same way. And they also assist facility teams with roadmap auditing and identifying whether current work meets the intention behind each roadmap element. And then on the far right, you can see that resources are also linked within the roadmap, and those include journal articles, expert recommendations, electronic order sets, and other pertinent tools that organizations may use to assist in implementation of those best practice elements. So again, these roadmaps are available on the MHA website. You just go to the quality and safety section, and from there, choose the HAI or infections option, and you'll see all the different topics with the roadmap within them. A little bit about MHA's program resources. So we have infection preventionists from hospitals and health systems that are able to participate in our peer learning network. And this has a focus on best practices, implementation science, any cross-cutting adaptive techniques, and formal and informal sharing of resources, review, and peer discussion or polling. And you're probably familiar with the targeted assessment for prevention strategy framework for quality improvement developed by CDC. And the TAP uses data for action to prevent healthcare-associated infections and consists of 3 different components. The first is running the TAP report in the NISN to target healthcare facilities and specific units with an excess burden of HAIs. The second is administering the TAP assessment tool to identify gaps in infection prevention in the targeted locations. And then the third is accessing infection prevention resources within the TAP implementation guides to address those gaps. So we've heard really great positive feedback around the TAP strategy and having that available to hospitals and health systems. And then we also have the HIIN user group, which is a venue for discussion of HIIN use within acute care and critical access hospitals. And typical agenda items consist of HIIN updates, case studies, any education or resource review, and then any upcoming HIIN events and time for question and answer. So it's a really good just networking group with HIIN. And then the Collaborative Healthcare Associated Infection Network, which is the HIIN partnership, represents a partnership that was formed in 2011, and it includes the APIC chapter for Minnesota, the Department of Health, Stratus Health, and MHA. And the HIIN coordinates across the continuum of healthcare delivery and supports patients, individuals, and families to prevent harm from infections acquired in the process of care and also combat antibiotic resistance. And so the group leverages the capacity of the members and resources, integrating and aligning related initiatives, and then breaking down silos and barriers to implement best practices. And HIIN serves as a resource to healthcare communities and each other. So it's a great working collaborative. There is an award that is offered each year. So we have applicants that submit the different projects they've worked on relating to HAI, and there are awards presented at an annual conference. And then we have additional support that's offered on our MHA website. So I'll just go over a few examples. Those are, so the MHA website includes many subcategories to infections. Again, those are antibiotic stewardship, you can see on the left side of the screen, CODI, CDI, CLABSI, influenza, SSI, and BAE. And there's many different videos and webinars available for use on things such as implementing an electronic hand hygiene monitoring system, human factors approach to hand hygiene, antibiotic stewardship toolkit webinars. There's a CDI toolkit and videos on environmental services staff training, central line insertion, staff education video, and then roadmaps on each of the topics. And then within those, many different tools and resources. So again, all of these are on the MHA website, and they are available for anyone to review and use. If you have any questions on any of those resources, or if there's something particular you're looking for, please feel free to reach out and we can help you look through our website to see if we have anything that might be able to help. So that is all I have for Minnesota. I can stop for any questions.
Hi, Jenny. We do not have any questions at this time.
Okay, great. Well, as Jenny said, if you do come up with any questions, please feel free to reach out, and I'm happy to help direct you in the right direction. And so now I'll hand it over to Kelsey Ostergren from the Michigan Health and Hospital Association. And Kelsey is the Senior Manager of Infection Prevention and Safety and Quality.
We will be talking a little bit about the TAP reports as well from the Michigan side, discussing some of the antimicrobial stewardship education we've done as well. Naomi, can you flip to the next slide, please? Naomi, can you move the slides forward, please?
You have rights as well to move the slides.
Okay, thank you. So I want to spend a little bit of time talking about the TAP reports. I think, as I mentioned, Jenny really teed this up nicely, but this is something that we have really been encouraging folks to utilize because I do believe it is an underutilized resource that NHSN and the CDC provides. And so this is the targeted assessment for prevention. And you'll see there's 3 different components: the T for target, the A for assess, and the P for prevent. And so before we really dive into this in more detail, I want to spend time briefly talking about the data measurement that is unique to the TAP methodology. Next slide, please, Naomi. I think we advanced a few. Can we go back a couple, please? Yep, that's perfect. Thank you. So the CAD is the unique kind of identifier that is part of what we see in the TAP reports. And this is our cumulative attributable difference. And so really what this number means, it's just simply a concrete prevention goal that is linked back to the SIR. So really this is the target number that you will get when you run a TAP report within NHSN. I did list both the formula for the CAD as well as the SIR, just so that you can kind of see the comparison between those two. And you'll see within the CAD itself, you're trying to focus on what that SIR goal is. So if you have a stricter SIR goal, you'll have that means basically you want to have a lower number of infections, which ultimately, based on this calculation, means your CAD will be higher. And so again, that CAD number strictly, that just tells us how many infections we want to prevent in order to get to whatever our SIR goal is. And we'll talk about how we use that number in running the report. So when you log into NHSN, this is kind of what your landing page will look like. If you go under analysis and then click on reports, you should pop up into, next slide, please. The acute care hospitals, and there's also long-term care and inpatient rehab if you have those facilities associated as well. But you will see there are the 4 different TAP reports you can run for CAUTI and CLABSI, as well as MRSA and C. diff. So if you click on those and click run, you will get an output. Go to the next slide. You will get an output that talks about your facility CAD. Okay. Oh. Couple slides forward, please. No. Okay, perfect. Yep. So this is just an example of a CAUTI TAP report. And again, this is just mock data. It wasn't pulled from any particular facility. But I just wanted to have an example so we could kind of look through it. So you'll see on the left side there, you have your facility name, and then you'll have your overall facility CAD. And so again, that is the number of infections you want to prevent in order to get to your goal. In this case, you'll see up kind of in the middle here, when I ran this report, I just left it at the HHS SIR goal of a 0.75. So again, that's the SIR that it's using in the methodology that it's calculating in order to figure out what my CAD would be. And so in this case, we have 0.8 infections, or I would round it up to 1 and say, okay, overall my facility needs to prevent 1 CAUTI infection in order for us to get to that goal. As you move over to the right side, and you'll see now we've broken it down by location. So these are the 2 locations or the 2 units that are in my facility, and it will rank them basically from worst to best. So if you're an infection control practitioner, if you're looking at this as a quality improvement, from a quality improvement standpoint, you would say, okay, my N2I unit is the one that needs the most work. I think this situation, again, if you look to that specific unit's CAD, which is circled on the right there, 0.81. So it's very similar to what our overall facility CAD is. For some facilities, some larger institutions, there may be, a handful or a dozen units, and there may be 2 or 3 infections needed to prevent per unit. And so this will kind of help you narrow down what units need the most attention. You'll see here in this example that the 2 East unit actually has a negative CAD, which simply indicates that that specific location has prevented actually more infections than what would be predicted for them based on their location type and the kind of patients they serve, et cetera. So if we move into the next slide, I took just a screen capture of the CDI TAP report. This will only be at the facility level, so you'll see here it is not broken down by unit. The CAD for this facility, again, is negative, a negative 16, which is pretty spectacular. So this facility would be considered a high performer. So they, again, prevented 16 more infections than were needed to meet the goal. And then you'll see as well, they have a SIR of 0, which I think a lot of us are more comfortable using the SIR as opposed to the CAD. And so that SIR of 0 just means that we saw fewer events compared to what we were expected. So all of this is what's included in the NHSN portal itself, and this comprises the T portion of the TAP report. So once we're done with this and we figured out kind of what units we think we need to focus on, or if we're running C. diff, which is at the facility-wide level, we kind of have some idea of what position we're in terms of how far we have to go in order to meet those goals. So we would take the information we have from this T portion, again, which comes out of NHSN, and move into the A portion, or the assessment. So if we flip to the next slide, I took just a screen cap of part of a facility assessment tool. And these tools, again, are specific to the topic area. So CAUTI, CLABSI, MRSA, or C. diff. This one obviously is a CAUTI example. So just make sure that you pull the assessment tool that corresponds to what you ran in NHSN. And really, I kind of think of these similar to a gap analysis. So this really helps us better understand what practices we're doing, what you're not doing, and really help us kind of zoom in on where our efforts for improvement will be best spent. I think as we encourage completion of tools like this, and it's been common for us through the gap analyses as well, I would encourage you not to sit at your desk by yourself and blow through this in 30 minutes. I would encourage you to be more intentional and thoughtful, collaborate with your quality improvement team, talk to those who are closest to the work, and really think critically about how you can improve in current processes. So as an example, if we look at item number 2, that's asking, is unit level leadership involved in CAUTI prevention activities? So let's say they are engaged. It would be easy enough for us to select, yes, they are, and move on. I think where the real benefit of this tool comes in is if we kind of take it to the next step of, is there a way maybe that we could engage them further? Is there another way that we could include them that would be more productive, or that would give us additional guidance? Really know how to get to the goal of what we're trying to do, in this case, in prevention. Again, this will kind of help us figure out those specific gaps and really how to target our improvement activities moving forward. So again, this is just one piece of the larger assessment. The full assessment is much longer. It's very thorough, and that will then give you the results to kind of begin looking at some of the implementation guides associated with your improvement. So the implementation guides is the P. So this is our last step in the TAP strategy, and this is the prevention. And so each of these 6 topics you'll see listed here correspond to one of the headings of the assessment that we just looked at. So if you identify perhaps that maintenance of urinary catheters is your issue as you complete that assessment, you would come to the implementation guide section, and these are all posted on the CDC website. And so you can go to that section specifically, you can expand it, and then you will see all the resources kind of listed there. And those, again, will be helpful once you've identified your gaps in order to figure out, okay, how do we close these, or how do we change our processes to be as effective and efficient at doing this improvement as possible. I think kind of as an overarching theme for the TAP strategy, my perspective from the conversations I've had with hospitals is that the A and the P, so the assessment and then this implementation guides are two pieces that really are not very commonly utilized. So again, I would just encourage you, if you're going through the TAP strategy, not to just stop with running that report in NHSN, but really kind of using that to jump into your assessment and then the resources that the CDC has for the prevention, because again, I think this is kind of a bundle that's intended to be used kind of comprehensively in order to really drive that improvement. So that's kind of a crash course in the TAP strategy, and happy to take questions as we get towards the end. The one other thing I did want to talk about from the Michigan Hospital Association standpoint for HAIs is related to our antimicrobial stewardship education. We can move forward the slide. Okay, perfect. So this is another program that the Michigan Hospital Association ran through the HIIN work. And so based on conversations that we kept having, it became apparent that pharmacists were not consistently involved in antimicrobial stewardship, in MRSA, and C. diff. And so as we kind of dug a little bit deeper into this, we realized that there was a lack of comfort or competencies, or pharmacists maybe didn't feel like that was really their role. And so what we did was we offered this antimicrobial stewardship certificate program that's specifically geared towards pharmacists, which was actually a program run by the Society of Infectious Disease Pharmacists. And so this program, you may be familiar with it. It's a self-paced program that has a 12-month completion window. It offers 40 CE credits for pharmacists, which I think was a big draw as well. And from our standpoint, it really focused on a lot of the topics that were central to the improvement work in the HIIN. So common commensal disease states such as skin and soft tissue infections, sepsis, and CDI, as well as diagnostic tests, antibiograms, and then implementation of an antimicrobial stewardship program. So within this program, there are actually three components. The first is an online educational module. The second are live webinars. And then the third is like a final capstone project that pharmacists can demonstrate what they've learned at their local institution. So this program it costs $750 per person. We were able to fund 10 pharmacists to participate in this and reimburse 2/3 of that expense. So I know financials can be tight, I think especially now with the impact that COVID has had, but we really felt that this was an important way to educate and engage pharmacists in the work we were doing, because this isn't a group that we had traditionally engaged with, but really felt that they were critical to help us be successful in the work. So this program actually launched last July of 2019. And so again, as I mentioned, it's a 12-month program. So we are in the final stages of kind of wrapping this up this month. And the feedback that we have received from pharmacists has been overwhelmingly positive. And I think from our standpoint, we were really excited to hear that. It's always great for us to engage a wider audience in the improvement work that we're doing, just so that we're not putting it all in the hands of the quality improvement or the infection control staff, but really how do we kind of broaden this out and really make this a larger team effort. So that kind of wraps up the antimicrobial stewardship piece. But I do kind of want to get a sense from this group, and I'm going to launch a poll here in a second, but I just want to get a sense of, is NHSN training something that you feel is necessary, you would be interested in? And I know that we have hospitals at different levels of comfort and familiarity with the data that they report. But just wanted to get a sense from you, from this group, as if that's something that you would be interested moving forward, so that we could kind of offer that if that is something that would be beneficial. So Naomi, are you able to launch the poll?
I launched the poll too fast, or the poll disappeared.
Okay, all right. Well, I guess if that won't work, if you guys are comfortable putting it in the chat box, sending it to either myself or Naomi, whatever you feel comfortable with. I do want to get a sense of, again, if that's something that this group would find beneficial, or if that's something you feel like you've been beaten over the head with. We certainly don't want to make duplicative work for you, and if you don't need it, that's totally fine as well.
We have 2 responses saying they do find it beneficial.
Okay, wonderful.
And a 3rd response saying that they would like more NHSN training.
Okay, so kind of a mixed group. All right, that's awesome. So if you can just keep chatting in what your thoughts are, if that's something you would like, if you have any ideas for what specifically you would be interested in, that would be helpful as well, just so that we can kind of formulate our thoughts. So we can certainly keep an eye on that as we move forward. And then in the interest of time, I want to pass it over to Annie Allen, who is the Clinical Quality Improvement Advisor at the Wisconsin Hospital Association, so that she can walk us through the work that the Wisconsin Hospital Association has done.
Trying to get back to the slides. I had the poll question up. Now it looks like there we go. Okay. All right. So good afternoon. I'm Annie Allen with the Wisconsin Hospital Association, and I'm excited to share with everyone 2 efforts that we have done here in Wisconsin over the last year and a half, 2 years, that went towards HII. So one of the things we did was we worked with a consultant company late spring, early summer, to do some CLABSI site visits with a couple of our hospitals. And we ran TAP reports for everybody who was participating in the HIIN, just like Kelsey showed earlier, to first identify which organizations would find the visits most beneficial. And then once we had sites that we identified and that wanted the site visits, we used those TAP reports again to work with them on which units specifically to focus on. Pre-site visit, we did have all of like the policies and standards of care sent by the organizations to the hospital association and the consultants, so that all of that review could be done ahead of time, so that we had a better idea of what line insertion and line maintenance and education looked like. before going on site. The site visits then consisted of 3 days. We did opening and closing sessions with leadership. We conducted gap analyses. We also looked at your internal RCAs. That's kind of where we could really dive deep and see if it was an insertion versus a maintenance issue, if there was any trends in that. We conducted staff surveys that helped us drill down to the education piece and what maybe needed re-education or more emphasis. And then we did lots and lots of observations, probably at least like a day and a half to 2 days of the 3-day site visit was observing insertions, dressing changes in all of the different units that those are happening. And then we conducted one-on-one meetings with the vascular access team if there was one, senior leaders, clinical education, infection prevention, anybody that had like insight into line insertion and maintenance. All of this got rolled up into a comprehensive report, which was presented to senior leadership at the close of the site visits. They did receive copies of that report. Some opportunities for improvement that were identified kind of across the board at all of the sites were education, choosing the right device, inserter competency measurement, ongoing surveillance and monitoring of devices, use of ultrasound guided peripheral IV insertion, and creation of a vascular access team or program when there wasn't one. The organizations then received regular follow-up from both the hospital association and the consultant company at 3 months, 6 months, and 1 year so that they could develop their action plan, and then we could help them with any pieces that they needed to work on. So just because we're done with the HIIN and we no longer have consulting services anymore doesn't mean that you can't use some of those same items to do some CLABSI improvement in your own organization. So this, for example, is a TAP report that I just ran the other week. And what this would kind of help you do is narrow down the location where you need to do some CLABSI work. And in this organization, that would be their med-surg floor and their oncology floor. This is an example of the staff survey that we conducted. And what we did was we just kind of went on every unit where we were doing observations. We just grabbed the nurses and say, here, hey, would you fill out this quick survey for us? And it actually really generated a lot of questions on the units and then made the nurses feel more comfortable with asking us questions. They'd say, hey, yeah, like number 10, I thought I would put this, but what is the answer to that? And all of these questions were developed out of the Journal of Infusion Nursing, Infusion Therapy Standards of Practice. So we could refer them back to that resource and say, okay, this is why, and this is where it came from. During the presentation to the senior leaders, then we took all of the staff survey results and presented it to them and said, okay, here, like we surveyed 60 of your staff, and in this example, only 54% were able to correctly answer number 2. So here's like some areas that your education department maybe could conduct a renewed focus. The other thing that this kind of helped us identify was changes in like dressing kit supplies. Sometimes when facilities make changes because it's cheaper, it doesn't always translate into, or it doesn't, like things don't stay the same. So we had found out from some of the staff nurses and talking about these survey questions, well, we used to have kits that looked like this, but now they look like this. And then digging deeper with nursing administration and the education department and finding out, oh, when the kit changes were made and what was made, eventually a decision was made to go back to the original kits because of the confusion it was causing and also the conflicting information with the recommendations for best practice. The second thing that we have done in Wisconsin over the past couple of years is conduct infection prevention boot camps. This was done in conjunction with the Department of Health Services HIIN committee. We have conducted them in a couple different settings, both focused for long-term care, ambulatory care, and hospital settings. It's a one-day in-person training that's kind of intended to cover the basics of infection prevention in Wisconsin hospitals. We like the in-person training, and hopefully we'll get back to that in the future because attendees can network. They have support once they return home. Kind of the idea behind the boot camp is that when people step into an IP role, sometimes they don't have an IP background necessarily, and that's a daunting task to step into running an infection prevention program in your hospital. So if we can, give them kind of the basics in policy development, surveillance, risk assessment, running an IP program, and then support and follow up with them and give them that peer-to-peer mentorship, they're going to be much more successful and stay in that role. So you can see some of the agenda topics. The website that's listed does have all of the materials from both the long-term care and the hospital boot camps posted on it. There's additional tools that's kind of meant to act as a virtual little orientation for infection preventionists in between these boot camps that will also be posted to that same site once the executive committee is done developing and reviewing those. So really quickly, that's just a couple brief things that Wisconsin has done over the past couple of years. And I will hand it back over to Naomi for final questions.
One of the final questions they were asking, and I'm not sure if they were asking this, but it's stating current evidence-based training for providers for regular collapse prevention.
Yeah, Naomi, this is Kelsey. I think that comment was related to the NHSN training and what topics they were interested in hearing about.
Gotcha. Okay. Then other than that, we actually do not have any questions within the questions box. So with that said, we would like to thank everyone for joining us today. And our next webinar will be next month. And we look forward to having you guys join us on that one. So I hope you guys all have a great rest of your day.